Well, Dr. Clark is going to give us a talk about painful knee arthroplasty.
Is this what advances the slides? Yeah? Okay. Good morning, everybody, / afternoon. Hope you guys don't all fall asleep on me. I know it's kind of getting late in the session. Okay, so I'm Dana Clark, and I'm a hip and knee replacement specialist at OCR. And what we're going to talk about this afternoon is potential causes of pain after knee replacement, why they fail, what we can do. So goals and objectives are to discuss the rates of success and failure with knee replacement, to describe some of the potential causes of pain and failure, and importantly, to differentiate between the intrinsic and extrinsic causes of pain. That's critical. To discuss some of the potential treatments, and also to discuss when to refer and what you should order prior to the referral. So let's talk a little bit about TKA. So as you all know, it's done for end-stage disease, okay? People have arthritic pain in their knee that's not getting better with conservative care. Cortisone injections, NSAIDs, PT, and the like. Total knee arthroplasty is not only one of the most common orthopedic operations in this country, it's one of the most common operations, period. It's done about 800,000 times a year. Fortunately, it's successful in the majority. Most studies say 85% success. But for a guy like me that lives in this world, 15% failure, it sucks, and I see it all the time. Generally, total knee arthroplasty is a durable operation. We anticipate getting 20, 30, 40 years of wear out of these modern-day implants. So, let's dive into these potential causes of pain. Intrinsic pain is pain that comes from the knee replacement itself. Extrinsic causes of pain is knee pain, but it's coming from the hip, it's coming from the spine, it's coming from elsewhere. And that's an important distinction, particularly for how we treat these people. If you look at intrinsic causes of pain, here they are. Infection, mechanical loosening, polyethylene wear, which is plastic wear, we'll get into that, instability, periprosthetic fracture, component malposition, that's crooked parts, and then bleeding into the knee or hemarthrosis. Infection is the most dominant cause of failure of all total knee arthroplasties, and it occurs in up to 2 to 4% of all knees. I want you guys to realize that infection can occur at any point in time in that life cycle of the knee. It can be early, right after the operation. It can also be late. And then another important distinction is it can be acute or it can be chronic. The way we diagnose infection is with laboratories and then importantly looking at the fluid inside the knee, the synovial fluid. As it relates to labs, hands down the best lab test is the C-reactive protein. It is the most sensitive test, not specific. The CRP can be up for all kinds of reasons, but generally if a patient is infected, the CRP is going to be up. SED rate's okay. I'll be honest, the white count, it's typically normal unless it's a bad acute infection. The aspiration is huge, and what I mean by that is we put a needle in the knee, draw fluid off, we send it to the lab, we send it for two things. We send it for a cell count, where they're looking at the number of white blood cells per milliliter of fluid, and if that number is greater than about 1,500 to 3,000, that's highly suspicious for infection. The other thing we look at is that differential. If we look at those white cells, if greater than 80% are polymorphs, probably an infection. The gold standard is the culture. Can we grow a bacteria? Most of the time we can, but unfortunately there are cases we can't. It's really, really important if you guys happen to send off a culture, always put down to check for P. acnes. That clues the lab in to hold it for 14 days. A lot of these organisms are little puny organisms that grow really, really slow, and we really need that 14-day culture to really be able to make a diagnosis. So let's talk about acute infection. This is not subtle. These people hurt like mad. Their knee is red, it's hot, it's swollen, and these people are sick. They're febrile, they've got an elevated white count, their CRP is up, their lactate's up. Oftentimes these people are bacteremic and septic, so it's kind of a big deal. Acute infections are kind of a little bit hard to differentiate within that first 6 weeks versus just that normal inflammatory response. I'm sure a lot of therapists in the room can agree with me. So many knees look infected early on. And the thing we do is we rely on our labs. We rely on what that fluid looks like. There's so much good data that tells us, okay, in 6 weeks it should be this. But if you're suspicious, just send that over. Let me make that decision. When it comes to acute infection, like I said earlier, it can be early or it can be late. So early, contamination in the OR, patients draining a lot, bacteria crawl into the wound, that's going to cause an early infection. And those are more common, but I also see late ones. Patient has pneumonia, they have a UTI, and they end up getting bacteremic, it seeds their implant, and they get infected. The bacteria that cause these infections are virulent, all right? Staph aureus, strep, E. coli, Pseudomonas, and really make people very sick. This is a surgically urgent problem. We do not sit on this. We do surgery the day we reach the diagnosis because this can be a deadly disease. Chronic cases, these typically present late and honestly can be kind of hard to diagnose. Most of the time, folks hurt a little bit. It's more annoying, moderate pain. They tend to be medically stable. This patient here has a fistula tract. I'll be honest, that's uncommon, but that would be the sign of just this chronic smoldering infection that eventually erupted out through the skin. Typically, the labs are going to be mildly elevated. The CRP is going to be just a little bit above normal, not 10 times normal. Sometimes on the x-ray, we're going to see some loosening of the implants. We'll get into that in a little bit. These bacteria tend to be indolent. So what we tend to see is staph epidermidis, P. acnes, things like that. And this is non-urgent surgery. And what I didn't talk about last time is when it comes to surgery with the acute infection, oftentimes you can get away with leaving the implants in place. We drain the pus, we debride the knee, we'll give them a new piece of plastic. But in chronic infection, you have to take the parts out. You will never win the battle. What ends up happening is that these bacteria grow a biofilm over the implants, and the only way to get rid of the bug is to remove everything. All right, next is mechanical loosening. This is the second leading cause of failure, and basically what it means is the parts have broken free from the bone. Fortunately, we see less and less of this because the plastic we use, the implants we use have gotten so much better. Usually this occurs late, so years and years down the line. It can occur early, that's a surgical error or typically infection. Usually this is a slow onset kind of chronic pain, and the classic complaint is startup pain. Patients first get up from a chair, they start walking, those first 5 steps hurt like mad, and as they continue to walk, that pain lessens. Usually these patients have a pretty obvious exam. If they're loose, they're going to have a big effusion, knee's going to be pretty irritable. Quite honestly, X-ray diagnoses the overwhelming majority of mechanical loosening. Some cases are subtle. We have to order bone scans, CTs, things like that. But even then are not perfect. But genuine mechanical loosening, I'm typically going to see signs on the X-ray. The dominant cause of mechanical loosening is plastic wear, okay? We'll get into that in a little bit more. But as the body reacts to that plastic particulate, it starts to absorb bone, it weakens the bone, parts collapse, people get loose. Infection is also a common cause. Anybody that has a diagnosis of mechanical loosening needs to have an infectious workup, period. This is always managed surgically. If somebody has a loose part, they're not going to get better. We revise whatever component is loose, and oftentimes we have to revise the whole knee. Okay, let's talk about plastic wear or polyethylene wear and osteolysis. So basically, polyethylene wear is the mechanical wearing of that plastic bearing, and that starts right away. As soon as that patient bends the knee, there's this microscopic plastic particle that gets generated, And for years and years and years, that plastic load is so infinitesimally small, it doesn't matter. But over time, as you lose conformity, as that plastic starts to get worn down, then the femoral component can start to shear on that plastic, and then we get this exponential load of plastic particulate, which our body does not like. The initial response is that our immune system generates a ton of fluid, people get a large effusion, they have pain, and if we can catch them here, oftentimes we can get away with just giving them new plastic. But unfortunately, if this goes on long enough, the immune system actually signals to our bone generators and destroyers to basically absorb bone, and that's what leads to the resorption and the loosening, and oftentimes at that point, we have to revise the whole knee. Fortunately, this is, I don't want to say it's gone, but we see so much less of it. So probably about 20 years ago, the plastic we use changed. We now use what's called highly cross-linked polyethylene. And basically what that means, polyethylene is the plastic, it's these chains, but they figured out during the sterilization process, if they radiate it at a certain frequency, they can create these covalent bonds between the chains. That's what we call cross-linking. It has changed the field of hip and knee arthroplasty. It is so much more durable and so much better. So bottom line, when it comes to polyethylene wear and osteolysis, you catch it early, there's no loosening, new plastic. If there's loosening, revise the whole knee. All right, instability, basically this is excessive ligamentous laxity, okay? It's the third leading cause of failure. It can result from surgical error. The doctor cut a ligament, put it in too loose. But more commonly, what I see is that patients, for whatever reason, just kind of stretch out over time, and that's when they become unstable. It's definitely a spectrum. You can have a fulminant case like this x-ray here where the knee's basically dislocating. I mean, that's obvious. These people can't walk, they're deformed, they need surgery. What I see more commonly, though, is this subtle stuff where patients have a little bit more laxity than they should, and essentially it leads to chronic soft tissue pain such as pes-anserine bursitis or IT band tendonitis. And basically what we do with these folks is we put them in PT. If they don't get better, then I talk to them about surgery. And I'll be honest, I try to talk them out of it because oftentimes it's kind of like flipping a coin. It's not the most predictable operation in the world. Sorry about jumping to that next slide early. Periprosthetic fracture. This is a lot more common around the hip, but it does happen around the knee. It's typically related to osteoporosis. I would say the classic patient is a geriatric, obese female with bad bone. This is always managed surgically, typically with open reduction and internal fixation, sometimes revision, and oftentimes both. Next, there's component malposition. This means the parts were put in crooked. Risk factors, obesity. Here you have this obese female with very large thighs. You can see she's in valgus or knock-kneed on both sides. It can be really hard to expose these people, and so obesity is definitely a risk factor to have this problem. People can also have some abnormal bowing of their bones, which messes up our jigs. That can also do it. And quite honestly, the most common cause is probably surgeon inexperience. I tend to see this in surgeons who have not been out for a long time, and they just don't have the clinical acumen to kind of pick up on this. So mild malalignment is not really a big deal. It's generally well tolerated. We just observe it. Severe malalignment is not. These people are unstable. It really throws off their hip and everything else. In addition to that, it can lead to early polywear, so we tend to revise those people. Hemarthrosis. That's a knee filled with blood. And it's surprisingly common, particularly nowadays when people are on Eliquis and Xarelto and Plavix and all the other crap they take. It's typically very painful. Ecchymosis is common, but not always there. It can look very much like an infection. The knee is typically red, hot, swollen. Their CRP can go up. Anticoagulant use is common. And bottom line, it's an aspiration diagnosis. Put a needle in the knee, you get a bunch of blood, there you have it. Single events, we manage those conservatively. We stop their anticoagulants, we immobilize them, they generally get better. Recurrent bleeds, those are treated surgically. That is typically the result of some instability. It allows the synovium to crawl in between the femur and the tibia, and you get recurrent bleeds there. So we typically revise those people. All right, next category, extrinsic causes of pain. When it comes to extrinsic causes, think of the hip, think of tendinopathies, psychiatric disorders, neurological disorders, and vascular disorders. The hip is a super, super common cause of people perceiving that their TKA has gone bad. And fortunately, these are the people I can help. Many people think their hip is here or here, but when you talk to them, they'll say, yeah, you know what, my groin hurts, and my thigh hurts, and my knee is killing me. When you examine these people, typically the exam is normal, their x-rays look fine, but when you examine their hip, they've got a decreased range of motion, they've got this positive impingement test that you see here. It's basically flexing their hip up, internally rotating, adducting. If somebody has bad OA, that's going to be positive. Another good test is the Stinchfield test. That's basically a resisted straight leg raise. People with bad hips tend to react to that as well. So, I really want to impress upon all you guys, anybody who has a painful total knee, they need a hip workup, at least an exam and an x-ray. X-ray findings here. For osteoarthritis, what we're going to see is this joint space loss that you can see on the left and on the right, bone spurs or osteophytes. Another relatively common hip disorder is this avascular necrosis, where the femoral head dies and it collapses and it acts very much like end-stage arthritis. Treatment in these cases is a total hip arthroplasty, and it works. And it's great when people show up to my office when that's the source, because I can help them. Tendinopathies, super, super common. The two I tend to see the most is pes-anserine bursitis, so pain here. Anteromedial aspect tends to bother them in stairs, things like that. They're typically really tender over the pes. The other one that's wicked common is IT band tendinitis. This is on the opposite. It's lateral. They tend to be tender over the IT band. These can be acute. They can also be chronic. Acute cases tend to get better with PT, NSAIDs, ice, and all the things we do. Chronic cases, believe it or not, are not that uncommon. They're super frustrating for me and the patient, and it's one of those things that patients just have to live with. Psychiatric or psychological disorders, I honestly think this might be the most common cause of chronic unknown pain. As we all know, people who have depression, anxiety, social dysfunction in their lives can develop physical pain as a result of that. So they get fibromyalgia. And what I tend to see in these people is their knee exam is normal, with the exception that anywhere you touch them, they hurt. And it's crazy, anywhere. I would say the most common patient is this previously sedentary, obese female who undergoes a total knee. They get so wrapped up in that post-op pain, they catastrophize over it, and then it sets into this chronic condition that just never goes away. It's very sad. It sucks. There's not much we can do for it, but it's common. Neurological disorders. First, I'm going to mention complex regional pain syndrome. It's exceedingly rare, but people think they have it all the time. It's so overly diagnosed. When it's real, it's a disaster. And typically what we're going to see is alterations in blood flow, temperature, hair loss, sensation. And more often than not, these people completely get arthrofibrosed. They can't move their knee. And it is an awful, awful thing when it happens. But fortunately, legit CRPS, in my opinion, is very rare. Lumbar radiculopathy is a potential cause, but generally, there's other stuff. People have numbness, tingling, their entire extremity hurts, they have back pain. Not real hard to sort that one out. Neuropathy is not that uncommon. And it's basically this hypersensitivity and pain that may be around the knee, but typically goes a little bit distal as well. I think everybody has this to some degree in the early postoperative period. It oftentimes disturbs their sleep, and the majority of the time that typically goes away, but there can be some more chronic cases that there's not much we can do for. Vascular disorders, DVT, we all know about that, I think. And usually this isn't just knee pain. It's thigh swelling, thigh pain, calf pain. And the other thing I want to let you know is a lot of early knees can look like they have a DVT. Bottom line, if you think they have it, get a duplex, and if they do, we treat them. Claudication, that's peripheral artery stenosis. There again, it's not typically just knee pain. It's leg pain in general that gets worse with exertion and completely gets better with rest. If somebody has claudication, you won't be able to palpate their pulses. And if you wish, send them to a vascular surgeon or do a vascular workup if you strongly suspect it. All right. The other thing I want to talk about is that most of the time, it's kind of this general gestalt feel in how we work these people up. Like I said, 15% of people are going to hurt. Most of the genuine cases where we could actually intervene, diagnose, and treat, it's not that subtle. Talk to them, examine them, get x-rays, get labs. Legitimate cases, honestly, are not that difficult to diagnose. So when to refer and who to refer to. In my opinion, any patient who has a painful total knee arthroplasty warrants a referral, period. Now, if they've had a referral, particularly if they've already had 3 or 4, you can stop referring. But if somebody has never had a workup, they absolutely need to be worked up. It is outside the scope of a general practitioner, and quite honestly, I think it's outside the scope of a general orthopedic surgeon. It's a complicated thing that, like I said, you have to have done this for a long time to kind of get that gestalt and feel. And the other thing I want to impress upon you guys is send them to a joint replacement specialist, not a general orthopedic surgeon. It's just a different level of expertise. So testing before referral, I'll be honest, I don't care if you guys order anything. I'll order what I need. But if you do, keep it simple. Get an x-ray, order a CRP and sed rate. If you can, get some old records and x-rays. Please don't order a bone scan. Don't order an MRI. Don't order a CT. Oftentimes those are not needed. They're just adding cost to the system. When to get excited? Not very often, but if somebody has a red-hot swollen knee, get excited, all right? Like I talked about, that can be an acute infection, which can lead to sepsis, which can lead to death. If you see a red-hot swollen knee, call OCR immediately. If it's over the weekend, send them to the ER. This is something you don't sit on. The other reason to get excited is if you strongly suspect they have a DVT. Obviously, that can turn into a PE and kill them. So get them to the ER, get a stat duplex. And lastly, if somebody has the severe onset of pain after trauma, they could have a periprosthetic fracture, they need an x-ray, they need an acute workup. But in general, most things can wait a week or two before we need to see these folks. That's all I have, folks. Questions? Yes? So I'm gonna answer that in 2 ways. Let's talk about life before highly cross-linked polyethylene, okay? And let's talk about life after. So before cross-linked polyethylene, honestly, it was like 10, 15 years. We would start to see osteolysis, start to see wear. I'll be honest, with new plastic, I don't see it. I do not see it. Yes? Say that again, please. Sure. Yeah, so the question is there a test you can do to assess for component malposition? First is physical exam. Are they crooked or not? Okay. Second is x-ray, all right? And if we want to dive into the weeds here, If somebody has obvious malposition, you're going to see it on x-ray. Their tibial component is crooked, their femoral component is crooked, but there can also be malalignment in the axial plane as well that you're not going to typically see on plain films. So in that case, we would order a CT scan, and generally what that would do is it would alter the patellofemoral mechanics. If the femur is rotated too far internally, the patella goes off laterally, so that would be an indication to do CT. But most of the time, just a plain x-ray and an exam is good enough. Yeah? So I want to make sure I hear you correctly. Do I ever recommend genicular nerve ablation for chronic pain after total knee arthroplasty? I think the jury's out, okay? I've never seen a well-done study that shows that it works and that it works in the long term. So I tend not to, but I think it's worth a go, you know? These people, they hurt, and it really sucks. And it's not a huge risk, and I think it's reasonable to try. Yes? Yeah, the answer is yes, okay? And essentially so the question is, does robotic total knee arthroplasty prevent malalignment, or does it help lessen it? And the answer is absolutely yes. And I'm going to go back even further, because preceding robotics, we used basically computers to navigate our cuts and things like that. And essentially what robotics and computer navigation does is it lessens the outliers. So in all the studies that have looked at this, let's say 1 to 2% of the time you had an outlier where a patient was in significant varus or valgus. Yes, the robot and the computer has helped with that. I'm not personally a big fan of robotic knee surgery just because of the cost and the additional time. And I think for surgeons like me that are doing 500 joints, 500 knees a year, you know, it's not subtle when you're doing it at that volume. So, thanks everybody.